Good day everyone, I'm Reloba, and in this video, I'm going to discuss about intracranial aneurysm. So an intracranial aneurysm is a saccular outpouching of a cerebral artery that occurs at the site of a weakness in the vessel wall. The exact etiology is unknown, but theories of a cause include a developmental defect in the vessel wall and the degeneration of fragility of the vessel wall due to conditions such as hypertension, atherosclerosis, connective tissue disease, or abnormal blood flow. The risk factors include the result of atherosclerosis, a congenital defect, trauma to the head, aging, or hypertension. Hypertension and cigarette smoking may be a contributing factor. A ruptured cerebral aneurysm is the most common cause of hemorrhagic stroke. Intracranial aneurysm tend to occur at the bifurcations and branches of the carotid arteries and the vertebrobasilar arteries at the circle of Willis, with most aneurysms located anteriorly. They range in size from smaller than 15 mm to larger than 15 mm. Intracranial aneurysms tend to enlarge with time, making the vessel wall thin and increasing the probability of rupture. There are several different types of intracranial aneurysm. A berry aneurysm is probably the result of a congenital abnormality of the tunica media of the artery. The aneurysm usually ruptures without warning. A saccular aneurysm is any aneurysm with a saccular outpouching which distends only a small portion of the vessel wall. This type of aneurysm is often caused by trauma. Meanwhile, in a fusiform aneurysm, the entire circumference of a blood vessel swells to form an elongated tube. Most aneurysms of this type occurs as a result of the changes of arteriosclerosis. Fusiform aneurysms act as space-occupying lesions. In a dissecting aneurysm, the tunica intima pulls away from the tunica media of the artery and blood is forced between the two layers. It may result from atherosclerosis, inflammation, or trauma. Mycotic aneurysm are caused by emboli from infections such as bacterial endocarditis. Intracranial aneurysm typically rupture from the dome rather than the base, forcing blood into the subarachnoid space at the base of the brain. The aneurysm may also rupture and force blood into the brain tissue, the ventricles, or the subdural space. An intracranial aneurysm is usually asymptomatic until it ruptures, although very large aneurysms may cause headache and/or neurological deficits due to pressure on adjacent intracranial structures. Small leakages of blood may occur periodically, causing headache, nausea, vomiting, and pain in the neck and the back. The person may also have prodromal manifestations before the rupture occurs, such as headache, eye pain, visual deficits, and a dilated pupil. The manifestations of a ruptured intracranial aneurysm and subsequent subarachnoid hemorrhage include a sudden explosive headache, loss of consciousness, nausea and vomiting, a stiff neck, and photophobia due to meningeal irritation, cranial nerve deficits, stroke syndrome manifestations, and pituitary malfunctions. The diagnostic test conducted to identify the site and extent of a ruptured intracranial aneurysm as well as rebleeding are a CT scan and bilateral carotid and vertebral cerebral angiograms. A cerebral angiogram is the gold standard for evaluating cerebral aneurysm. It can demonstrate the source of the aneurysm about 80 to 85% of the time. A lumbar puncture will reveal a blood-tinged spinal fluid. The main complications of a ruptured intracranial aneurysm are rebleeding, vasospasms, and hydrocephalus. The greatest risk of rebleeding is within the first day after the initial rupture and again in 7 to 10 days when the initial clot breaks down. Rebleeding is manifested by a sudden, severe headache, nausea and vomiting, decreasing levels of consciousness, and new neurological deficits. The mortality from rebleeding is as high as from the initial rupture. Cerebral vasospasm is a common but dangerous complication that occurs between 3 and 10 days after a subarachnoid hemorrhage. It is associated with a large number of deaths and disability. A cerebral vasospasm narrows the lumen of one of the cerebral vessels, causing ischemia and infarction of tissue supplied by the affected vessels. The actual cause is unknown, but it occurs in blood vessels surrounded by thick blood clots, suggesting that some substance in the clot initiates the spasm. The manifestations vary according to the degree of spasm and the area of brain affected. Regional alterations may cause focal deficits such as hemiplegia, whereas global alterations cause loss of consciousness. Hydrocephalus is an abnormal accumulation of CSF within the cranial vault, and dilation of the ventricles is a potential complication of a ruptured intracranial aneurysm. Hydrocephalus is thought to be the result of obstruction of reabsorption of CSF through the arachnoid villi. The obstruction is caused by an increased protein content of the CSF because of lysis of blood in the subarachnoid space. The accumulation of CSF increases intracranial pressure. Initial manifestations of hydrocephalus are typically nonspecific but commonly include decreasing levels of consciousness. There are different management for intracranial aneurysm. In pharmacologic management, calcium channel blockers such as nimodipine are used to improve neurological deficits due to vasospasm following subarachnoid hemorrhage from ruptured intracranial aneurysm. Administered for 21 consecutive days, they have been found to enhance collateral blood flow and reduce the incidence of ischemic deficits from arterial spasms without side effects. Other medications that may be prescribed include anticonvulsants such as phenytoin to prevent seizures if the person has increased intracranial pressure, analgesics for headache, and stool softeners to prevent constipation and straining with a bowel movement, which increases intracranial pressure and blood pressure and may cause rebleeding. Several types of procedures are used to repair a ruptured intracranial aneurysms or to prevent the rupture of an existing large aneurysms. These include the skull is open or craniotomy and the aneurysm is located. The neck of the aneurysm may be clipped with a metal clip preventing the entry of blood into the aneurysm, or the involved artery may be clipped both proximally and distally to the aneurysm to isolate the affected area. Endovascular Guglielmi detachable coils are a method used to treat non-ruptured aneurysms. One or small platinum coils are inserted through the microcatheter and threaded through the carotid or femoral artery to the site of the aneurysm, where they are released and fill the body of the aneurysm. The coils initiate the immune response and the body produces a blood clot inside the aneurysm, strengthening the artery walls and reducing the risk of rupture. After the aneurysm is stabilized, it can be clipped with less risk of hemorrhage and death. However, endovascular coil procedures are also effective without surgery, especially for smaller aneurysms. Next is stents, which are coil or mesh tubes introduced into the body through a catheter are used to cover the neck of an aneurysm, while coils are deposited within the body of the aneurysm. Balloon remodeling is used for large, multiple, or surgically inaccessible aneurysms. A balloon is placed across the neck of the aneurysm and coils are inserted into the body of the aneurysm. The balloon prevents the coils from moving out to the aneurysm. Lastly, parent vessel occlusion is performed to occlude the parent vessel that supplies blood to the aneurysm. Prior to permanent occlusion, the risk of neurological impairment is assessed by monitoring motor, sensory, and cognitive functions in an awake person while temporary occlusion is conducted. For the nursing management, these interventions are for the care of the person immediately after the intracranial aneurysm ruptures. The expected outcome of care is preventing rebleeding and improving cerebral tissue perfusion. First is to institute aneurysm precautions to prevent rebleeding as follows. Keep the person in a private, quiet, darkened room. Disconnect or remove the telephone. Avoid using bright overhead lights. A quiet environment helps prevent an increase in blood pressure which could precipitate rebleeding. The person may experience photophobia or abnormal sensitivity to light if hemorrhage has damaged the oculomotor nerve. Next is to elevate the head of the bed 30 to 45 degrees. Follow prescribed activity orders, usually a complete bed rest, but in some cases, bathroom privileges may be approved. Elevating the head of the bed promotes venous return from the brain and thus decreases intracranial pressure. Decreasing activity reduces the likelihood of increase in blood pressure. Limit visitors to 2 family members at a time and limit the duration of visits. Monitor the person's response to visitors and decrease interactions if the person becomes agitated or upset. Psychological stress may increase blood pressure and the risk of rebleeding. However, social isolation may increase anxiety and stress. Each person and family must be individually evaluated. And next, allow reading, watching television, or listening to the radio to promote relaxation. Although these passive activities were previously contraindicated for the person on aneurysm precautions, current therapy is based on the belief that these activities promote relaxation and help control blood pressure. Next is to prevent constipation and straining to have a bowel movement. Administer stool softeners as prescribed, and collaborate with the person and doctor about the use of bedside commode or the bathroom. Do not administer enemas. The person is at risk of constipation as a result of decreased mobility and the administration of narcotics for headache. When straining to have a bowel movement, the person uses the Valsalva maneuver, which increases intracranial pressure and may precipitate rebleeding. If the person is alert and depending on the doctor preference, allow them to feed self and provide own personal care. In many instances, self-care causes less anxiety and stress than care provided by the nurse. The extent of care provided varies according to the person's condition and the doctor's preferences. The person who may have to go to the operating room will be kept by mouth.
Ruptured intracranial arteriovenous malformation. They believe that in almost to their cases, it develops during the development of a child in utero, and basically involves 2 different kinds of blood vessels that should not be directly connected, actually being connected. In the body, we have arteries, which are the vessels that carry blood from the heart to the rest of the body. The arteries are thick-walled and are designed to carry high flow and high pressure of blood. Once the blood gets to where it ever going into the body, the arteries split again and again until ultimately they get into the capillary, which are the tiny microscopic vessels where the oxygen is given to the tissue of the body. Once the oxygenation takes place, it's the veins that takes the blood back to the heart from the brain, and the veins are very thin wall that designed to carry low blood pressure, slow flow blood back to the heart. So the arteries and the veins are quite different in how they are built and really should not have blood direct communication. In EVM consists in area for some reason. During development, the arteries and the veins are directly connected by a very tiny network of a very small vessels, where there are basically no pressure drop that happening. So you have the high pressure blood going straight from the arteries into the veins as a kind of short circuit. That pressure builds up to the point where there is a weak spot and eventually rupture causes to bleed. Thankfully, the initial bleed is often contained by the surrounding pressure in the skull. This allows the clot to form, which temporarily stops the flow of blood, stabilizing the patient. These are the factors predispose EVM to bleed: hypertension, history of a prior bleed, deep venous drainage, higher feeding artery pressure, and intraneedral aneurysm. The signs and symptoms are severe headache, seizure, syncope, progressive neurologic deficits, and hemorrhage. In vital signs, BP, normotensive or hypertensive, HR, mild tachycardia may present, and RR is dyspnea. Complications are hemorrhage, reduced oxygen brain tissue, thin or weak blood vessels, brain damage, and stroke. To diagnose EVM, the test may include cerebral arteriography and CT scan or MRI. And medications may include antihypertensive drugs, sedatives and stool softeners, and analgesics. Surgical management. One way is surgery. You just cut it out. And if you remove the AVM, the goal is making it to go away. And hopefully, you've taken away the risk of bleeding. A second way to treat an EVM is with radiation. It's kind of like getting a sunburn. If you treat an EVM with radiation over a period of time, those blood vessels begin to thicken up, and they begin to close off the tubing that blood travels through, and the end result is that the AVM shrivels up. And hopefully over a period of time, months, years, that EVM disappears. The third way is to treat it with embolization, where you can thread a very tiny wire through the blood vessels inside the body. You can squirt different types of agent to plug up the pipe from the inside, which can help to slow down or stop the flow of blood inside an EVM. Nursing intervention. Assess pain using the patient's self-report whenever possible. Note headache onset and severity, presence of stiff neck and insidious onset of confusion, disorientation, decline in consciousness, and/or focal deficits or weakness of extremities. Assess neurologic status using Glasgow Coma Scale and assess for changes suggesting increased ICP and herniation. Be alert for subtle changes and new focal deficits. Another is assess for factors that can cause increased ICP. Evaluate the patient for restlessness, distended bladder, constipation, hypovolemia, headache, fear, or anxiety. Maintaining patient airway and administer oxygen as ordered to prevent hypoxemia. Institute measures to minimize external stimuli and maintain BP level. Administer antihypertensive drugs as ordered to control blood pressure. Sedatives and stool softeners may be prescribed to reduce agitations and straining. Then monitor ECG continuously because hypoxemia and cerebral bleeding are risk factors for pronounced ST segment and T-wave changes and life-threatening dysrhythmias. Monitor ICP, analyze the ICP or intracranial pressure waveform, and calculate CPP or cerebral perfusion pressure every hour. Then monitor BP and pulse every 15 to 30 minutes initially, then hourly. And encourage patient to keep friends and family close and find someone to talk with. And encourage to avoid smoking and maintaining a healthy diet or healthy lifestyle.